Hello.
Sir, I'll just confirm you once it goes on live streaming. Just a moment.
Okay. Till then, Dr. Deepti,
Yes, sir.
can you send the link to Dr. Pavan? I sent him. He said he has not received it.
How the Sandeep?
Zoom link. Huh?
Huh.
Okay. Who will be presenting today?
Dr.
They're not
Vinila
live
is
yet, no?
not yet.
Okay.
Who is somebody is raising hand? Samsung SF. I don't know. Okay, Vinila will be presenting third now palsy. No, sorry, proptosis.
Sir, you are live. You are live now. Yeah.
Okay.
So good evening, postgraduates. We welcome you to the second session of case presentation and Viva VOC today. And today we have the three cases, which are proptosis, third nerve palsy, and retinal detachment. We have with us Dr. Krishna Prasad, who is HOD, Department of Pediatric Ophthalmology, Glaucoma, and Oculoplasty in MM Joshi Eye Institute. Along with him, we are expecting Dr. Pavan, who is professor from WIMS Bellary, as well as Dr. Sandeep, who is professor in Hassan Institute of Medical Science. So both of them, they will be joining us shortly. So we have Dr. Vinila with us, who would be presenting proptosis case, Dr. Neelambika, who would be presenting to us the third nerve palsy case, and Dr. Nikita, who would be presenting to us RD case. So kudos to all of you girls. I think without wasting much time, we would proceed with the first case presentation, which would be by Dr. Vinila, and that would be a case on proptosis. Followed by that, Dr. Neelambika would be presenting her third nerve palsy, and finally Dr. Nikita would be there for retinal detachment, and that would be moderated by Dr. Guru Prasad sir, who is HOD, Department of Retina, MM Joshi Eye Institute. So all the best to all of you. Over to Dr.
Do we have
Vinila.
any Viva tutorials or any instrumental session from you?
Sir, if
today?
This ends like today, yesterday it ended very late, so I thought in case it ends early, I would then I'll take up the Viva VOC part, sir.
Okay, fine, no problem.
Yes, sir. Okay.
Okay. So let me, start off till our other examiners join. Okay, let me start off and without wasting much time, since we are already live and the students are ready to present, and other people will be joining on the YouTube. So as I said in the first primer class, case presentation is like a storytelling. So you need to actually tell the most relevant details of the case that you saw. Obviously, these are only cases on the PowerPoint, but in a real life situation, you'll be seeing an actual case. You may be seeing that case in a place where you're not familiar, not a familiar institute. The patient may not know your language. Okay, at the same time, you'll be hard pressed for time, and you will be obviously under the great pressure of, after 3 years of your post graduation, that will be a very defining moment for you. So you will be under a lot of cortisol surge. With keeping all that in mind, whatever your work that you have done in last 3 years will definitely come handy. So some kind of a simulation exercise, some kind of a familiarization exercise would be definitely indicated. So whatever case that you are presenting, the similar case won't come in the exam. There will be some variation. Like, for example, a cranial nerve palsy. It may be a very acute, a very fresh case with all the findings. The case may be 4 months old, and a lot of recovery will be there. Okay, you may have a fungal ulcer, fulminant, acute, progressive. You may have even a healing ulcer. You may have an ulcer with perforation. You may have, okay, combined bacterial and fungal ulcer combination. So there can be a lot of variations. So whatever you are presenting, so we will try to discuss all those combinations that are possible, so that you will be ready for all kinds of such things. But nevertheless, whenever such a case is presented, there are some basic rules that you need to adhere to. First of all, don't waste too much of time in the formalities. Okay, you should be able to present quickly without much pauses between the your sentences, and always tell the most important thing first. For example, don't have confusion in very common things. whenever I see exam students presenting in the exam, the mistakes are usually done in a very typical way. For example, vision. When you are telling the vision, there is a particular way of doing it, which every examiner actually confirms and they follow. So don't make mistake in that. And vision is most important. Okay, so obviously you can make a mistake in something less important or something which is not known to everyone, but the basic things you should not falter. So at least avoid the heartburn of those steps. So be very clear. So in this mock presentation, I welcome Dr. Sandeep Kapu, who is the a teaching faculty in the Hausen Institute of Medical Sciences. He's a vitreoretinal surgeon in his specialty, but an excellent comprehensive ophthalmologist also. So welcome, Dr. Sandeep, for the mock case presentation and Viva Voce. So
Good
this
evening,
is
sir.
the so we will start with the first case without wasting much time. Dr. Pavan will join us
Sir,
very soon.
1 minute. I have one
Yeah.
more person who has joined with eye to eye name only. Can you just identify yourself so that I can rename, so that we will know when we are addressing the corresponding person? There is some other person who has joined with the name eye to eye. If I can just get to know who is it, if you can unmute and let us know. Or is it Guru sir or Pavan sir? We would just like to know who has joined recently with us.
I think once their video is on, we'll come to know.
Kotak Tilas. I think Pavan sir. I'll rename
Pawan.
him, sir. Yes.
Okay, okay. Dr. Pavan, you are very familiar. We don't need the name. Everybody knows you. Okay, so with your permission, Dr. Pavan and Dr. Sandeep, we will start the first candidate to start a presentation.
Okay, sir.
Okay, so you both can actually keep your audio on so that you can keep talking and interrupting and also interacting with the students. Yeah, Dr. Vinila,
Yes, sir.
you are the one. Yeah,
Yes,
please
sir.
go ahead.
Good evening, everyone. Today I will be presenting a case of a 60-year-old gentleman hailing from Gadag, who is a farmer by occupation, who presented to us with the complaints of prominence of the right eye associated with diminution of vision since the past 2 years. The patient was apparently all right 2 years back when he first noticed the prominence of his right eye, which was painless, insidious in onset, and gradually progressive. Patient also had associated complaints of diminution of vision for both distance and near, which was gradually worsening over the past 2 years. So the prominence of the eyeball, as explained by him, was constant with no worsening associated with change in posture or any pain or double vision. So there is no prior history of trauma to the eye, no history of loss of appetite or loss of weight, no history of fever, redness, watering, no history of similar complaints in the past or in the other eye, no history of any previous ocular surgeries or use of any chronic medications. So there is no significant past history and no history of any previous ocular or systemic surgeries. Patient has no history. Coming to the medical history, there is no
No,
history of
just a
any
minute. Wait,
thyroid.
can you stop?
Yes,
Uh,
sir.
did you ask the patient, does he have any kind of swellings in the other parts of the body?
Uh, no, sir.
Why I'm asking you this? Is
Sir,
it relevant?
if yes, sir, it could be secondary metastasis to the orbit, which
No, no. If you have multiple swellings all over the body or some parts which are hidden
uh,
by the clothes and you have a proptosis, what is the connection?
it could be neurofibromatosis.
Yes, okay, it could be
In which case he could
neurofibromatosis
have
one.
uh,
Okay,
sir, it could be a manifestation of a melanoma which has and secondaries from a melanoma.
but you said it's a 2 year history, right?
Yes, sir.
So do you think it could be a malignant tumor?
No, sir. Unlikely.
Okay. So then in the, let's say in the history, how did you differentiate? Let us say, we don't know, it's just a proptosis.
Yes, sir.
Considering it as an orbital space occupying lesion, what all the things that you would ask to differentiate a benign from a malignant tumor? What all things in the history?
Sir, the type of onset, if it was sudden or insidious in onset, if it is the progression, sir, if it was sudden or uh, sudden progression or sudden increase in size, or if the gradually progressive, if the patient had pain or is it a painless mass, if there's any recent history of sudden increase in size, uh,
What about
any
motility restriction?
if there is any
Double vision?
motility restriction, and
What about
also, sir,
vision?
Vision
about-
also might be drastically reduced if the patient it's a malignancy as compared to a benign long-standing tumor.
Does this patient has loss of vision in that eye,
Yes, sir. He has associated loss of vision in the same eye.
in the same eye?
Yes.
Okay. So go ahead.
So, coming to the medical history, patient has no systemic illness. He's not a diabetic, no history of any thyroid disorder, or not a known hypertensive. Coming to the personal history, he consumes a mixed diet. Sleep, appetite, and bowel bladder habits are normal, and there is no relevant family history. Coming to the general physical examination, a patient is moderately built and nourished. He is conscious, cooperative, and oriented to time, place, and person. The pulse rate was 80 beats per minute. Blood pressure was 130 by 80 millimeters of mercury, and the respiratory rate was 12 per minute. And there is no pallor, icter, cyanosis, clubbing, lymphadenopathy, or edema. The systemic examination of the cardiovascular system, respiratory system was found to be completely normal. The cranial nerve examination was found to be normal, and there were no motor or sensory deficits. Per abdomen examination was also found to be within normal limits. Uh,
Cranial
so,
nerve examination other than the optic nerve.
optic nerve, yes, sir.
Okay. Okay. Hmm.
So, coming to ocular examination, there was no abnormal head posture. There was facial asymmetry due to the right eye proptosis. The ocular alignment was found to be ortho in the primary gaze. Uh, Vision in the right eye was finger counting close to face, which was not improving. And color vision and finger confrontation could not be assessed due to the poor vision. In the left eye, the vision was 6 by 9 for distance as per Snellen's visual acuity chart. And near vision was N6 with a plus 2.75 add. Color vision and finger confrontation tests were found to be within normal limits.
Hmm.
So shall I share the picture?
Yeah, please. Yeah, make it full screen.
Yes, sir. So coming to the inspection of the right eye, so we it is a unilateral abaxial proptosis of the right eye with inferior displacement of the globe. The ocular movements were found to be full and free in all gazes. So there were no fullness of the eyelid, edema or injection, lid lag or lag of thalamus, but there is found to be some amount of lid retraction. Uh, the MRD1 was found to be 8 millimeters and MRD2 was found to be 6 millimeters. Sinus examination was found to be within normal limits. The right eye prominence was also noted in the worm's eye view and the Nafziger's view. And there was no change in proptosis associated with Valsalva maneuver or forward bending. And there was good Bell's phenomenon, no exposure keratopathy, and no lid lag. Uh, Coming to the palpatory findings, there was no local rise of temperature or tenderness. The orbital margins were found to be intact. Finger insinuation was not possible between the globe and the superotemporal orbital margin. Firm gritty mass was palpated in this region, which was non-compressible. There was firm resistance on attempted retropulsion, and there was no palpable thrill. There was anterior displacement of the
Now, which
globe of
quadrant is the mass that you felt?
the
Which quadrant?
superotemporal.
Superotemporal.
Yes, sir.
If the mass is predominantly superotemporal, where will be the displacement of the globe normally?
Sir, it should be downwards and medial.
Okay. So then
Uh,
what do you actually think?
So superotemporal, my first differential would be lacrimal gland tumors.
Hmm.
My second differential would be a lymphoproliferative disorder.
Hmm.
Then it could also be a dermoid.
Okay, no. Basically, don't just jump with that. That's not so simplistic. This patient has actually a proptosis. So
Yes.
majority of the mass is behind the eyeball.
Hmm.
What you're feeling is only superotemporal quadrant. It
Yes.
doesn't mean that the mass is restricted to superotemporal quadrant.
Yes.
You get that point?
Yes.
So the just is just an area where you're feeling the mass.
The
Whether the
mass,
mass
yes.
is predominantly behind a much posterior plane. That's why the eye has come forward.
Alright.
Okay.
Yes, sir.
So are you feeling the mass? What is the feel of the mass?
Sir, it is a firm, gritty mass that
If it
is
is a gritty
palpated in the
mass, what are
superior.
the possibilities that you think of?
Uh, Sir, it could
Normally, a
be,
soft mass, a fluctuant mass versus a gritty, harder mass.
sir,
Do
a
you have any
gritty, harder
differentials for
mass.
each one of them?
Sir, a soft mass, it could be a hemangioma
Hmm. Cavernous
or
hemangioma.
cavernous hemangioma or dermoid.
Okay. Hard
Whereas
mass?
a
Hmm.
hard or a gritty mass, it could be either a lacrimal gland tumor, it could be an osteoma.
No, no, no. Osteoma, that's why you said finger insinuation. The why whatever mass you're feeling, if there is a gap between the orbital margin and the mass, if you can put your finger between the two, then it is not arising from the orbital
Bone.
margin bone.
Yes,
It
sir.
is not a bone tumor. If there's an osteoma, ossifying sarcoma, or you will probably ossifying fibroma, you will actually feel there is a continuity from the
Yes,
orbital
sir.
margin. So that is the thing, that it is not arising from the
From the bone.
orbital bony margin.
Okay.
Okay, so it could be a nerve sheath tumor, neurofibroma, or it could be
Yes,
even a lacrimal gland tumor. Okay,
yes, sir.
go ahead.
Uh, so in palpation, there was no local rise of temperature or tenderness. Orbital margins were intact. Finger insinuation was not possible in the superotemporal quadrant, and a firm gritty mass was palpated in this region, which was not compressible. There was firm resistance on attempted retropulsion, and there was no palpable thrill. Uh, there was no anterior displacement of the globe noted by 24 millimeters from the lateral orbital rim as measured by the Lewis exophthalmometer, and a 2 inferior displacement of the globe as measured by the two ruler method. There were no loss of periocular sensations, no regional lymph node enlargement, and no palpable neck mass, and there was no bruit on auscultation.
Okay, what neck mass you are actually referring to?
Sir, if the patient has any goiter, if it is, we can rule out
Thyroid
thyroid eye
swelling.
disease.
Okay, you should be very specific that there is
Yes,
no
sir.
obvious thyroid swelling.
Yes,
Okay, so then we connect the two, right?
yes.
Okay.
Uh,
Can this be thyroid? Whatever you have presented, can this be
yes, sir.
thyroid?
Sir, there is only lid retraction, and there are no other thyroid eye signs that are there.
Hmm.
But it will definitely be a first differential because the most common cause of unilateral and bilateral proptosis is thyroid eye disease.
No,
No, but
it doesn't
the
work
finger
that way.
insinuation.
Out of, let's say, 100 cases of similar cases that you see of
Yes,
proptosis, most will be thyroid. Okay. It doesn't mean that if a patient has a tumor and the eyeball is coming out and now no thyroid signs are fitting into that, you can't really put it as thyroid just because it is more common, most common.
mhm,
Okay. Let us say out of 100 cases, 95 are thyroid, but other five are not thyroid. No.
yes, sir.
If there is a lot of things against thyroid, first
Mm,
of all, it is a unilateral thing. It can be still unilateral, but there is a
yes, sir.
proptosis and there is a lid retraction, which is, even though there are a lot of other lid signs that have to go with this.
Mm,
The lid retraction may be because of the eyeball being pushed forward,
yes, sir.
or maybe the tumor is probably infiltrating the superior orbital region. So that could be the reason for the lid retraction.
Yes, sir.
Okay. Do you have all that other surface signs, congestion and other things, temporal flare, other things of thyroid in this? No,
Mm,
right? So there's no corneal exposure.
no, sir.
Hmm? Okay, but still, thyroid can be a DD, but may not be the first DD. We are already
Yes,
feeling a mass in the supratemporal quadrant.
yes, sir.
Does it make it thyroid? Okay, so don't tell in the exam just because thyroid is the most
Most.
common cause of proptosis. You can't make, when you're feeling a palpable mass in the orbit, don't say thyroid first.
Yes,
Okay, that is not the way to look at it.
yes.
Okay, continue, please.
Coming to the examination, ocular examination, the right eye conjunctiva, there was minimal bulbar conjunctival congestion in the interpalpebral area and no prominence of vessels. The cornea was normal in shape, size, luster, transparency, and sensation. Anterior chamber was found to be quiet. Iris was normal in color and pattern, and there were no neovascularization of the iris. Pupil showed grade 1 RAPD. The lens was clear. Anterior vitreous space was normal. The intraocular pressure was 16 millimeters of mercury as measured by Goldman's applanation tonometry at 11 a.m. And coming to the left eye, adnexa and conjunctiva were found to be normal. Cornea was normal in shape, size, luster, transparency, and sensation. The
Anything
anterior chamber
abnormal in the
is
left eye? Nothing.
no, sir. IOP
Okay.
was found to be within normal
What are
limits.
the most important signs that you want to tell me in the right eye
Uh,
in the examination? He has a pupillary abnormality.
he has a pupillary abnormality, sir. There is a lid retraction of 2 mm.
Hmm.
There is abaxial proptosis with slight inferior displacement.
Hmm.
And finger insinuation was not possible in the superotemporal margin, and a firm gritty mass was palpated in the superotemporal area.
No, what about the pupil?
Uh,
You said
Pupil
there's
had
an.
grade 1 RAPD, sir.
Is it an important sign?
Yes, sir.
Why? What
It
is
is
the?
suggestive of optic nerve involvement, either direct involvement of the optic nerve or external compression of the optic nerve by the mass, mechanical compression.
Can you give me at least a diagnosis to suggest one of these two possibilities? What diagnosis you are suggesting? An RAPD. So you
Uh,
mean it's a tumor compressing the optic nerve, or it is a tumor arising from the optic nerve?
so it could be a tumor that is compressing the optic nerve,
Hmm.
arising from the
You can't
superotemporal
have a
quadrant,
tumor
and
arising from the optic nerve.
we can, sir, but in
What
that
is the
case, if it's an
diagnosis?
optic nerve sheath meningioma, then most likely he should have an axial proptosis,
Hmm.
which could explain the loss of vision as well as the grade 1 RAPD.
No, you can't rule out an optic nerve sheath meningioma in this. But only thing is you
Okay.
have a mass in the superotemporal quadrant, which is very unlikely that you can't have a mass extending up to there from the, it's usually a thickening of the optic nerve sheath itself. So
Yes,
which
sir.
causes a very profound vision loss. Okay. So you said it's only grade 1 RAPD, but the vision is very poor.
Yes, sir.
Does it match?
Mhm.
Okay. So you can continue with your findings. What about the
Uh,
fundus?
Sir, fundus examination of the right eye on indirect ophthalmoscopy using a 20 diopter lens. The media was found to be clear. The disc was average size with well-defined margins. It was pale in appearance with a CD ratio of 0.3:1. The blood vessels seemed to arise from the center of the disc and were dichotomously branching with an AV ratio of 2:3. In the right eye, there was also choroidal fold seen in the superiorly. And the left eye fundus, as
Your
measured
disc is
as
okay.
seen, disc is pale, sir.
Disc is pale. So
Yes,
what
sir.
does that indicate?
Sir, it indicates optic nerve involvement,
No, no, optic nerve compression, compressive optic
compression.
neuropathy from the tumor,
Yes,
most likely, right?
yes, sir.
So that will explain the vision loss.
Yes,
Okay. Left eye fundus was normal.
yes. The left eye fundus was completely normal.
Okay. So now what is your diagnosis? Provisional diagnosis.
Sir, my provisional diagnosis of the right eye would be avaxial proptosis with inferior displacement, most likely due to an intraorbital space occupying lesion, possibly involving the superior quadrant of the orbit. And the left eye would be presbyopia. Fake, fake, yeah.
So it is an orbital SOL.
Yes, sir.
What SOL DDs that you want to give?
Sir, since it is a superior SOL that I'm suspecting, my first differential would be a lacrimal gland tumor, uh, then a neurofibroma.
Hmm.
Uh, my third differential would be a frontal mucocele.
Frontal mucocele, you cannot insinuate the finger between the two. No, it will be an extension from the, it will be a continuation from the frontal
Frontal
margin.
sinus. Hmm.
No, you can also have, can you have a neurolemoma?
Oh, yes, sir.
Yes, so all such hard gritty masses, once you
Hmm.
say neurofibroma, you can always say in the exam neurolemoma.
Okay.
Neurolemoma arises from the peripheral nerves of
Nerves.
the orbit.
Yes, sir.
Okay, not from the optic nerve.
Yes, sir.
Okay, so can we have schwannoma? You can
So
have a schwannoma of the
schwannoma
nerve.
of the peripheral nerve.
Yeah,
Yes.
so there are a lot of nerves there. So schwannoma, neurilemomas, they all have a similar physical picture, okay, of a
Yes, sir.
gritty hard mass. They're all nerve sheath tumors. So you can have all of them, but not a soft mass like a cavernous
Cavernous
hemangioma or a
hemangioma.
dermoid.
Yes, sir.
Okay. So now what is your line of investigation? How do you want to manage this case?
Sir, I would first like to get a radiological investigation, contrast, plain CT and a contrast enhanced CT. We have the pictures, sir. So the contrast enhanced CT shows an ill-defined, heterogeneously enhancing soft tissue lesion in the superior retroorbital aspect of the right orbit, involving the superolateral extraconal compartment with minimal intraconal invasion abutting the superior rectus, lateral rectus, and the optic nerve.
Hmm. Okay. So now next, what do you want to do?
Uh, Sir,
Now you have
since
a
we're suspecting
radiological
a
diagnosis and you have the extent. Okay, you also know the texture. It is not cystic.
yes,
So
sir.
it's a hard mass. You know the extension. It doesn't go into the brain or into the temporal fossa. So what do you want to do with this now? Would you like to
Sir,
know what mass it is?
yes, sir. But if it is a lacrimal gland tumor, benign or malignant, we should withhold from doing a biopsy. So we can go ahead with a excisional biopsy of the entire tumor.
Excision biopsy means orbitotomy.
Orbitotomy.
So what is the
And
approach to this particular tumor in the orbit now?
uh, sir, we can do a lid split incision or a lateral approach.
Is it intraconal?
It's extraconal, sir.
So would you like to go to lateral orbit?
Mm.
So it in the superior orbit. It will be very easy to
So
do a vertical lid
vertical
split.
lid split.
Okay,
Yes,
it's
sir.
of Byron Smith. You do a vertical lid split and go inside. You will be able to remove this mass
Yes.
very easily because it is extraconal and also in the superior orbit. So vertical lid split, that is the superior orbitotomy with tumor removal, and then you subject it to histopathology.
Yes.
And depending upon the histopathology findings, you need to go ahead with if it's a malignant or benign and what exactly kind of tumor, okay,
Yes.
that you need to. So the takeaways from this case is whenever, as I told you in my first class, the proptosis will be a case if it is around that time of your examination. In that institute, if
Mm.
there is a case which is posted for surgery or it has come to the OPD in a few days before that, that will be definitely picked up and kept. And
Yes.
normally they don't keep a malignant tumor with very symptomatic one. Normally these tumors which have been long standing, okay, the cavernous hemangiomas or dermoids or any bony lesions of the orbit would be the usual thing that they keep it. Very importantly, what you need to do is to understand how exactly you need to put across the history. So make a diagnosis, make a differential diagnosis, and especially uh, inspection. Is it an axial proptosis, abaxal, which will show exactly the location of the mass in the orbit? At the same time, you should also know that you should not miss it for a pseudoproptosis. So
Yes.
here the question that will be asked is, if you don't find, if SOL is not a diagnosis, what are the
Mm.
causes of pseudoproptosis, which you may confuse it for a unilateral proptosis?
Sir, it could be a unilateral high myopia, or it could be a lid retraction, or it could be a contralateral ptosis or enophthalmus. Uh,
Okay. So what about bilateral pseudoproptosis?
uh, it could be a bilateral high myopia.
Bilateral high myopia. See, even all our craniofacial anomalies like
Huh.
upwards, Crousens,
Yes,
and
sir.
very shallow
Craniosynostosis.
orbits, there's actually not a proptosis. Only the orbit is shallow
Hmm.
for the normal sized globe. There is no
Yes,
tumor
sir.
pushing the thing forward.
Yes.
So even all these craniofacial anomalies with shallow orbits, okay, Crouzon syndrome, upward syndrome, they are
Yes.
the ones which actually have is kind of a bilateral proptosis-like
Proptosis.
picture without having any orbital problem, except the
Yes.
shallowness of the orbit. Okay, so these are the things you should be ready. And FNAC, you should know what all, as you said, that's a good idea that not to do an FNAC in a lacrimal gland tumor because you may breach the capsule and it cause a dissemination. So even before the surgery is taken up. So if it is not a lacrimal gland tumor, if it is, let's say, a vascular tumor, like if it's a contrast enhancement is there, then also we don't put. So for lesions which are arising from the lacrimal gland and also the region, I mean the lesions which are like the vascular lesions like hemangiopericytomas and cavernous hemangiomas, we don't normally. So it would be best if it is easily approachable, it would be best to actually take it out and then subject it. If it is extensive, very posterior, not easy, amenable, then you may probably put in a needle and try to find out the cytopathological diagnosis before planning it, especially in case of malignancies.
Malignancy.
Frank malignancies or secondaries, FNAC would be very handy. Okay, and investigation, radiological investigation of choice for orbital lesions is always for CT scan
Yes.
because CT scan is a glorified X-ray. It depends on basically the tissue's transparency to X-rays. Since bone is very important part of the orbital imaging, bone is very well visualized on CT scan. So you can know the bony as well as the tissue differentiation, and you can know the extents of the lesion. But the catch is if the tumor is posterior, if the tumor is near the apex, apex cannot be imaged by CT scan well because the bone is very close to each other. You may not really find the tissue differentiation at the orbital apex. Orbital apex, you should go for MRI. But MRI basically depends on the water content. The bone has very little water. So any bony lesion, so don't go for MRI.
Yes.
Whereas apical lesions, MRI would be the ideal choice. Okay. So Dr. Sandeep, are you there?
Yes, sir.
So you can probably ask one or two questions and then we can go to the next case.
Yes, sir. Dr. Vinila,
Yes, sir.
so I will give you one tip. Whenever a examiner asks, can it be, can it be like that? You have to tell yes first. Even though if you know or don't know, just tell because he wants you to tell that answer. Okay, it will be
Okay, sir.
usually. Can it be just like in all India entrance and state entrance? It will come. No, that word if it comes, usually it is a positive thing. Okay.
Okay, sir.
Second thing is there any contraindication of MRI to this patient?
Uh,
So what are the contraindications for MRI? That is the
Sir,
question.
if the patient has any metallic implants like a
No,
pacemaker,
here is there any contraindication?
sir, since
Uh,
it is very superficial and we
no, no,
want
no.
to see if
Whatever I am telling, whether in this patient you are presenting a case, whoever you are presenting, in
yes,
that
sir.
patient, is there any contraindication of MRI? Yes or no?
In this case, there is no contraindication as
No.
such, sir.
Yes, if there is no contraindication, as Sir KP Sir said, first
Mm.
option will be CT.
Yes.
Then, before deciding the procedure, you can have a MRI also. Okay.
Okay, sir.
And the newer trend is the 3D imaging.
Hmm.
Okay, that you have to uh, read more because now the newer trend is 3D imaging of
Yes, sir.
the 3D radiological imaging so that
Yes.
you will get a better and idea when you are operating. Okay,
Yes, sir.
second thing. Third thing is what is your diagnosis, final diagnosis, clinical diagnosis, both imaging and clinical picture together. You have to come to a diagnosis. Is your diagnosis is differential diagnosis or diagnosis? What is your diagnosis?
Uh, Sir, my diagnosis would be a lacrimal gland tumor, possibly benign in etiology. Uh,
Okay, you have done imaging.
yes, sir.
In imaging, can you make out it will be a benign or malignant?
Sir, if it is a well circumscribed,
No,
homogeneously
here
enhanced,
only you have to tell about the
here,
case.
okay. Uh,
Forget about theory.
yes,
Let
sir.
us be practical.
Uh,
Is there any bony invasion?
there is no bony invasion, sir, but
So, so radiologically, it looks like a benign
benign tumor. Yes,
lesion.
sir.
Have you
Yes.
done any blood test?
No, sir.
That is very important.
Yes, sir.
That is very important.
Hmm.
Before telling your arbitrotomy, surgery, procedure, and all, because it's a major surgery, no arbitrotomy.
Yes, sir.
So, but you have to do a blood test that where you have missed. That is
Hmm.
very basic and important thing. Hmm?
Yes, sir.
Okay,
Okay.
proceed.
Dr. Sandeep, we have another two cases. So I think we'll move to the next case.
Okay,
And
sir.
you
Okay, sir.
can keep questioning the second candidate. So thank you, Dr. Vinila.
Thank you, sir.
So please, incorporate all the changes and keep it up.
Yes, sir.
And can we have the second student who will be presenting the case, Dr. Neelambika, right?
Yes, sir.
Okay.
Okay. Can I
So
start, sir? Am I audible?
yeah.
Okay, sir. Uh, 50-year-old female patient came to the OPD with chief complaints of sudden onset double vision since 10 days and drooping of left upper eyelid since 7 days. So patient was apparently all right 10 days back when she noticed double vision, which was sudden in onset, constant, which was relieved on closing of one eye at a time. It was maximum in the right case. This was associated with deviation of the left eye in the downward and outward direction. This was followed by drooping of the left upper eyelid after 3 days. This was insidious in onset and progressive in nature. It was not associated with any diurnal variation. There was no alteration in amount of drooping with ocular movements. There was no history of trauma or any recent illness. There was not associated with pain, glare, or diminution of vision, especially for near. No associated headache, nausea, vomiting, or blackouts were seen. So, the personal history, the patient is a known case of type 2 diabetes since 10 years and is on medications for the same, but the patient has poor control of diabetes. There is no history of any hypertension, no history of any other systemic disease. The past history does not show any similar episodes in the past, and there is no history of any surgical procedure done in the patient. The general examination, the patient was well oriented to time, place, and person.
No,
And
you can
the
come to
vital.
vision. You can come to ocular examination.
Okay, sir. Okay. Shall I just share the screen?
You're showing the photograph.
Yeah. Yes, sir. So this is the photograph of the patient. Sir, on ocular examination, the head posture was normal, facial symmetry was present. The extraocular movements in all gazes were documented as follows. The right eye, all movements were extraocular movements were full and free in all 9 gazes. The left eye, we can see that there is a limited elevation, limited adduction and depression. The uh, the um, abduction was normal. Then coming to the vision, the right eye had an uncorrected vision of 6.6. The near vision was N10. Sorry, I'll just keep this. The best corrected visual acuity, the patient improved with a plus 1.5 near addition to N6. The eyebrows were raised. The eyelids were normal. Cornea was clear with normal sensations. The
No,
anterior
just can you
chamber was of.
stop? Can you? I want to interrupt. Dr.
Yes,
Neelambika,
sir.
why there is no head posture?
So there is complete ptosis in this patient, this
Hmm.
severe ptosis. So on on any uh, on any action, the patient is unable to see with that eye, which is why there is no head
Okay.
posture.
Okay. Fine. ठीक है. So on lifting the lid, what is the
Yes, sir.
position of the eye?
It is
On
in the
lifting the
primary
lid,
gaze.
where do you see the
Yes.
eye? In
On lifting
primary
the lid,
gaze,
it
what
is
is the
deviated.
position of the eye?
It is deviated. It is abducted, sir.
No, it is not abducted. It is out. I mean, it's
It is
basically there
outward
is
and
a
downward. Yes.
out and down. Okay.
Yes, sir.
So can you tell me why it is out and down? What exactly you are
Uh,
thinking?
Sir, I'm thinking of third nerve palsy, sir. Uh, because the outward
Hmm.
movement is because of the LR action, unopposed action of lateral rectus, and the slightly downward is because of the unopposed action of superior oblique muscle.
Okay. ठीक है. Now go ahead with the examination.
Okay, sir. Uh, uh, So the right eye, the anterior chamber was of normal depth. The iris was normal color and pattern. The pupil was round, regular, reactive to light. The lens was clear. The IOP with Goldman applanation tonometry at 11
Why are
a.m.
you
was
specific? Is there a specific thing that you want to impress upon with the pupil examination here, or is like a routine pupil examination?
Sir, in third nerve palsy, there may be involvement of the pupil, which so we may see a a slightly enlarged pupil or not reactive to light uh, in the
Slightly enlarged
affected eye,
pupil or can a dilated pupil?
dilated pupils.
Dilated pupil. So you may have a loss of
And I
pupillary
see.
reaction. You may have a
Yes.
loss of direct reaction. You may have a dilated pupil. So pupil may be involved in such a situation. In that case,
Yes,
the
sir.
entire thing changes. So you should very specifically, you don't present the pupil like any other case. Here you say
Yes, sir.
specifically, I have looked for pupillary reaction. It is normal to direct and consensual. That means to say that you are telling the examiner that you know that something can go wrong in the pupil in this case.
Yes, sir.
Okay? Yeah, go ahead.
Okay, sir. Okay, sir. Sir, on the fundus examination with 90D and a slit lamp biomicroscopy, the right eye shows a normal shape and size of the disc. The color is also normal. The neuroretinal rim is healthy. The CDR ratio is of 0.3. The vessels arising from the disc are dichotomously branching and with an AV ratio of 2s to 3. We can see a yellowish white fuzz with fuzzy border lesion present just supero-nasal to the disc, which is suggestive of a cotton wool spot. There are presence of multiple small red dots which are present in the macular area, suggestive of dot blot hemorrhages. And there are present of there are multiple small yellowish discrete lesion present around the macular area, which are suggestive of hard exudates. uh, uh, Coming to the left eye, the disc is of normal size and shape. The CDR ratio is 0.3. The vessels arising are again dichotomously branching with an AV ratio of 2s to 3. There are multiple yellowish discrete lesions present around the macula, suggestive of hard exudates, and there are also presence of multiple red dot-like lesions present in the mid-peripheral area, which are suggestive of dot blot hemorrhages. Um, so
What
my
is the vision of the
provision,
patient?
it's 6/6, sir, in both eyes.
Okay, fine. ठीक. Yeah.
So my provisional diagnosis is a right eye presbyopia with moderate non-proliferative diabetic retinopathy with clinically significant macular edema, and a left eye presbyopia with pupil sparing third cranial nerve palsy with severe ptosis with moderate non-proliferative diabetic retinopathy with clinically significant macular edema.
Your diagnosis is incomplete, no? You just can't say it is third nerve palsy. No, you need to tell the etiological diagnosis. The third nerve palsy is a finding.
Yes, sir.
So third nerve
Uh,
palsy can come because of host of things, right? You
yes, sir.
don't want to really further tell me why third nerve palsy?
Sir, ischemic mononeuropathy most likely because of diabetes.
Ischemic mononeuropathy. We don't use that word that often. We say diabetic mononeuropathy. So
Yes,
most
sir.
likely due to diabetic mononeuropathy. Okay. Okay.
Yes.
Actually, we have Dr. Sandeep and Dr. Guru Prasad himself, who are the retina specialists. So now the discussion in a typical case like this with them will be more on your retina rather than the third nerve. Okay. So now
Okay.
Which one you want, you are interested in now? Anyway, we have another case of retina fundus case anyway coming up. So I think, so why do you think it is third nerve palsy, number one?
Sir, because of the restriction, the limitation of movement and the limitation of movement in other gazes are more likely suggestive of a third nerve palsy. So, the lateral rectus, the abduction movement of the left eye is normal, and also we need to check for the superior oblique
So
movement
by the
as well.
pattern of the
But
motility restriction, it is suggestive of third nerve palsy, right? Why do you
yes,
think
sir.
it is diabetes?
So the patient has a history of poor control of diabetes, sir,
So any patient
and
of third nerve palsy with a poorly controlled diabetes has to be a diabetic third nerve palsy.
no, no, sir,
Is it so simple?
not
1 plus 1 is equal to 2.
no,
You
sir.
can't have any other intracranial problem causing a third nerve palsy. So why do
Yes,
you
sir.
think this is diabetic third nerve palsy? Why not it is some kind of a different cause, some intracranial cause, maybe life-threatening cause?
Sir, usually life-threatening causes like aneurysms or any neurosurgical causes are pupillary involving. They most likely aneurysms which are at the junction of the posterior communicating artery with the internal carotid artery at that area. So it usually affects the pupilomotor fibers which are present superior-medially on the optic nerve in that area.
Okay.
So which uh, so because in this case it is pupillary sparing, I am thinking of a more likely a medical cause. Mm.
Okay. Excellent. So now tell me very quickly, next 10 minutes we'll cover this. How do you want to proceed with this case?
So first of all, since this patient has just a history of 10 days of involvement, so the first likely we want to ask the patient, we have to observe the patient. We have to advise the patient to have a good sugar control. We can also investigate for CBC blood profile and sugar profile for this patient. Along with the sugar control, the first around it, they should usually get better on its own around around 6 weeks, and we can give it up to 3 to 6 months of a time. And up till then, once the ptosis starts improving, the patient will
No,
likely
no, no. Don't go
experience
till there.
diplopia.
Wait. So you have signed up. You're already very sure that it is diabetic third nerve palsy, right? So you don't want to really rule out any life-threatening intracranial causes. You're so sure that
We
the
can.
pupil is not involved, you will bet your money on it's a diabetic palsy.
No, sir.
Yeah.
We should go for a
The-
city.
yes. It is not difficult nowadays to get an imaging. Patient can afford, it is accessible, affordable. And just because it is not 100% accuracy, we can say that just because the pupil is not involved, it can't be a surgical cause.
Yes, sir.
Okay. So it is not like that. So basically, there are few things. Only thing is, if it is a badly controlled diabetes, patient had earlier other cranial palsies which recovered. So looking at the patient profile, you can actually wait for certain things. But definitely, if somebody asks you this question, you should err on the side of a neuroimaging. One
Yes, sir.
neuroimaging you can rule out. Now I want to ask you which part of the brain you want to do imaging
Um,
and what investigation? CT, MRI, X-ray. Which one?
so I would like to do MRI with MRA, possible.
MR?
The MRI with MRA angiography, magnetic
For
resonance.
what? Where? Which part?
We want to see vascular. Uh, Sir, in the uh, uh,
So
near
basically,
the
even an
caverns.
MRI would be fine. Maybe gadolinium enhanced MRI for basically midbrain. That is the area of the third nerve and the basically the course of third nerve. So basically, in and around midbrain and the course of third nerve, if you can image, it is fine. So that is exactly where you may have a glioma of the midbrain compressing on it. As you said, a PCOM aneurysm can be compressing. There can be in any other lesion. There can be some kind of a pachymeningitis. There can be any other lesion elsewhere pressing on this. It could be there. So just a imaging is not really out of place here. You say clinically it appears like a diabetic palsy because of its appearance. Patient is a badly controlled diabetic and pupils are spared. Still, I would like to rule out any intracranial causes or surgical causes. I would like to do a screening, okay, with neuroimaging, even though I am very sure that this could be diabetic mononeuropathy. At the same time, if you don't do any imaging, but after 5 days, the pupil may get involved. It's only 10 days, right?
Yes,
So it
sir.
is not that somebody has taken a scissor and cut the third nerve. It is an infiltration which can happen and the pupil can be involved later. You don't know how it
Yes.
progresses. So in the course of your follow-up, if there is a no recovery, number one, okay, even there is no recovery that happens, or if there is an addition of new neurological findings like pupil involvement or some kind of a focal neurological deficit, sensory or motor, okay, then you need to do a neuroimaging immediately. So if you are actually can do in any case as a primary event, so that you are sure. Or you can defer the neuroimaging in case you find this. Somehow this patient keeps on improving with time. Every week it starts improving, then you may probably defer it also. So, but at the same time,
Yes.
you should be very clear on this neuroimaging part, right?
Yes.
So this is the thing. So then what do you till you the recovery happens, you would like to do anything? Like Dr. Deepthi would
So
definitely do something for this patient during the course of the recovery. She will not keep quiet. So what she is going to do? Tell me. Do you think I'll leave this patient for 6 months, watching
no,
every
no,
six?
sir. Serial follow-ups.
Okay, I'll do serial
He
follow-up.
has.
Every fortnight I'll follow up to 6 months, not doing anything to the patient. Just say control diabetes and come back.
Uh, so if once when the ptosis starts improving, the patient may again complain of diplopia. So we can give the patient temporary Fresnel prisms.
Prisms?
Correct.
Mm, no. See, the biggest problem for Dr. Deepthi in this case is a contracture of lateral rectus.
Yes, sir.
Because of unopposed action, by the time it recovers in 6 months, I won't come to midline because the LR will go for a contracture.
Yes.
Okay. So how do you avoid a contracture?
We can give a botulinum toxin
Yes.
injection.
One is by even
JR.
patching. If you patch the other eye also, the MR tends to act and there can be some amount of the stretch of the LR. Second is botulinum toxin injection to the lateral rectus, which will expedite the recovery. I mean, fasten the recovery and also reduce the contraction. Okay.
Yes.
So you just want to treat the ocular motility only. You don't want to treat the retina. There are two retina specialists in
No.
this panel now.
Yes, sir. Actually, since the vision is 6 by 6, according to the protocol, we can still observe the patient. We would all, of course, like to
So
do a
we just went back and saw, I think the optometrist has checked the vision wrongly. The vision is 624 in the right eye and 612 in the left eye, not improving. Then
uh,
Dr.
we
Sandeep,
can give.
you are there? Dr. Guru Prasad? Okay. Before they start asking you, tell me what do you do with
Yes,
this?
KP, I just came.
Okay, sir. You saw the retina. The patient has moderate NPDR with this was the retina finding with she said thing. So you can give me your comments quickly and then we can go to the last case, sir. So Dr. Guru Prasad will now, uh, ask you something about her retina. We have just asked about third nerve palsy, which is anyway going to improve since it's a diabetic mononeuropathy. But this problem at the back won't improve, right? So how do you
Yes,
want to manage this retina? You can answer to Dr. Guru Prasad and Dr. Sandeep.
Dr.
sir.
Nilamika,
Yes, sir.
please go ahead. How will you manage this retina?
Uh, Sir, I would like to do a retina, a macular OCT for this patient to see exactly if involvement of the fovea and uh, correlating with the vision. If the vision has also decreased in this patient, if it is below 6/9, then I would like to advise this patient um, injection bevacizumab, and I
Did you
would like
say,
to.
one moment, did you say that if the vision is good, 6/9, and the central involvement is there, then you will advise injection, or even otherwise you will advise injection? Did you say
Sir,
that the
yes,
vision is important or the central involvement is important?
the center involvement is the central involvement is important. Yes, sir.
Why is the vision not so important as compared to the involvement of the center? No, vision is good, but the center is involved. Are you worried or not worried? Vision is good.
Yes, sir, I'm worried.
You're worried. Good. I want you to be worried because it can involve, it can become chronic. The vision can get involved in future.
Yes, sir.
So that is what should be the cause of your worry. So how will you manage further? We talk about
Sir,
one
we can.
Yeah.
Sorry, sir, I couldn't hear.
No, continue.
Sir, we can give the patient injection bevacizumab, anti-VEGF, and we can follow up the patient and do a repeat macular OCT to see the. We can give three serial injections, monthly injections of anti-VEGFs, and do.
What is it called? What is that pack of three called? Pack of three injections called monthly injections. There is a name for that. Three injections.
Yes, sir.
It's called the
I
loading
don't
dose. Okay.
loading dose.
Okay. So why anti-VEGF? Why not steroid? Or else the question can be, what are all the other pharmacotherapeutic agents you know to reduce macular edema?
Mhm. We can give steroids, intravitreal steroids.
Any other anti-VEGF you know?
Mitral. So we have bevacizumab. We can give aflibercept, ranibizumab.
Hmm. Any others you know?
Or
Any
sir,
newer ones?
pegapten, brolucizumab,
Trastuzumab, correct. Any other you know?
faricimab.
Paracimab, very nice. Very good. So you seem to know all the anti-VEGFs. So when will you choose anti-VEGF and when will you choose steroid?
Mm. So the first line is usually anti-VEGFs
Okay.
on if not improving on if it's a persistent macular edema not improving despite giving anti-VEGF therapy for 6 months at least, then we can switch to steroids. And also in um,
Which study said that steroids can be the first line and it works as well as anti-VEGFs?
mm,
So
I don't
steroids can be
remember.
the first line. The study is MEAD study.
Okay, sir.
MEAD MEAD study.
Okay, sir.
So how often will you do the injections?
We can give 1 monthly injections, and then after the first 3 injections, we can do a monthly OCT of the patient. If the edema has resolved, then we can call the patient on the next visit and then inject and keep checking and then injecting
You
if
want to call the
required.
patient every month. He has to come from his village every month and get
We
examined,
can
have the OCT done. What is
we
that
can
called?
also give
What is that monthly visit
Prorinat
and OCT every month called? I mean, what is that
Prorinata, sir.
protocol called?
Prorinata, sir.
Prorineta, very good. Anything else you know other than Prorineta?
Um, Mm, I don't remember the
So
name.
supposing the patient comes after 3 injections for the fourth injection after 1 month, and you find that the macula is dry, that means the fovea is not anymore involved. It is still not edematous. In that case, you can extend by 15 days.
Treat and extend. Yes, sir.
So every time you can keep extending by 15 days depending on whether the macula is dry or whether it is affected by edema.
Yes, sir.
So you can extend up to 3 to 4 weeks depending on what drug you're using. It doesn't happen with the bevacizumab or ranibizumab. It happens more with the longer acting sustained effect of aflibercept and brolucizumab and Vabysmo, that is faricimab. Okay. So these are the drugs with which you can try the treat and extend, but with bevacizumab and ranibizumab, treat and extend is rare. Rarely it meets with any success. Right.
Yes, sir.
I think we can go to the next case.
Thank you, sir.
Yeah, thank you, Neelambika. You're Neelambika, right?
Yes, sir.
Which college?
Sir, I'm at Nandadeepai Hospital, Sangli.
All right. Okay.
Very well
Thank you,
presented, Nilambika. All the best.
Thank you, sir. Thank you, sir.
So can we have Dr. Nikita?
Yes, sir.
Okay.
Am I audible, sir?
Yeah, very clearly audible, and you have the fundus case, right?
Yes, sir.
Okay. Dr. Guru Prasad and Dr. Sandeep, Dr. Pawan will be there. You can please go ahead.
I'm presenting a case of Mr. H, who is 54-year-old male engineer from Bagalkot, has come with complaints of diminution of vision in the right eye since 20 days. He was apparently normal 20 days back when he developed diminution of vision to right eye, which was sudden in onset, painless, progressive, both for near and distant objects, without any diurnal variation. There is history of accidental trauma by a child's hand twice to right eye, 5 months back once, and the 1 month back once. So history of floaters present from 4 to 5 days before the diminution of vision. No history of flashes of light. No history of distortion of images. No history of episodes of transient vision loss. No history of head injury, loss of consciousness, weakness of limbs. No history of redness, watering, discharge. Ocular history, there is no history of any ocular surgeries in the past, or patient needed glasses for near vision from past 5 years. Medical history, patient was diagnosed with diabetes 4 years, and he is on oral medications since 1 year. Patient.
Dr. Nikita, just hold. Take a breath. Okay. You said sudden loss of vision?
Yes, sir.
From how many days?
20 days, sir.
Can you tell me at least top 3 causes of sudden loss of vision in a woman of that age?
Since there is history of trauma, sudden onset diminution of vision, traumatic optic neuropathy, or any vascular occlusions.
When did the trauma happen?
Trauma
To a
happened.
child's hand, you said.
Yes, sir.
So how can a child really, hit
Child's
the
hand to the head.
So that can cause traumatic optic neuropathy and sudden loss of vision after so many days again. Is there a temporal sequence? Traumatic optic neuropathy happens soon after the trauma, and trauma is usually serious enough, severe enough, right?
Yes.
Okay. So do you think this trauma can... No, right?
No, sir.
So traumatic optic neuropathy is not your first, DDs that you are giving. Sudden loss of vision, standard undergraduate answer. What is it? Sudden loss of vision in any patient.
Sir, I'm not.
Sudden loss of vision.
RD, sir.
Huh?
RD or any vascular occlusion, CRAO.
Yeah, I mean, keep telling.
CRAO, CRVO, or optic neuritis can happen suddenly. VH.
You seem to be fond of short forms anyway. VH, then?
Sorry, sir. Cataract progression, but cannot be.
Sudden loss of vision is usually from the retina or optic nerve, right?
Yes, sir.
So as you said, retinal detachment, vitreous hemorrhage, vascular occlusion like CRAO, CRVO, optic neuritis. Rarely it can be hyphema, but usually be associated with trauma. Okay, and traumatic optic neuropathy. This is like when we say sudden loss of vision. It is not with an antecedent trauma.
Yes.
With just a spontaneously sudden loss of vision.
Nikita, you told most of the differential diagnosis or causes of sudden loss of vision
Yes.
in a middle-aged
Okay,
person.
so your history taking should encompass keeping this in mind. Your history taking is a very tailor-made history taking, knowing the diagnosis already, right? Okay, so always when you're taking a history, anybody can ask you this. Did you consider all the DDs and then take the history to rule them out in the history? Okay, so please go ahead where you stopped. From there, you continue.
Family history, no history of similar complaints in the family. Personal history, diet veg, appetite good, sleep adequate, bowel and bladder regular. General physical examination is a middle-aged man who is moderately built and nourished, conscious, cooperative, and well-oriented to time, place, and person. Pulse rate of 95 beats per minute, BP 110 by 80 millimeters of mercury. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. On systemic examination, cardiovascular system, S1, S2, normal, no murmurs, central nervous system, normal, motor sensory system, higher mental functions are normal, respiratory system, bilateral, normal vesicular bed sounds heard, no added sounds, per abdomen, soft, non-tender, and no organomegaly. Ocular examination, head posture normal, facial symmetry maintained, ocular alignment normal, vision, right eye, PL positive, PR is inaccurate, near vision he could not appreciate. Left eye vision 6/9, not improving with pinhole. Near vision with plus 2.25 diopter cylinder N6. In intraocular pressure, right eye 8 millimeters of mercury. Lids, adnexa, sac are normal. Cornea is normal in surface, shape, sheen, transparency, and sensation. Anterior chamber normal in depth and content. Iris normal in color and pattern. Pupil is pharmacologically dilated. Lens, nucleus sclerosis grade 3 with cortical cataract. Anterior vitreous examination were found to be having fine pigmented particles floating in the anterior vitreous, which was suggestive of tobacco dusting. Ocular movements were full. Left eye, sir. Left eye, lids and adnexa normal. Cornea normal in surface, shape, sheen, transparency, and sensation. Anterior chamber normal in depth and content. Iris normal in color and pattern. Pupil round, regular, reactive. Lens, nucleus sclerosis 2 with cortical cataract. Anterior vitreous normal. Ocular movements full. So fundus examination on distant direct ophthalmoscopy, right eye showed gray reflex. Slit lamp microscopy and IDO with the 20D and 90D lens. Right eye media is hazy. Disc normal in size, shape. Sir, should I share my screen, sir?
Yeah, please show the photograph.
Sir, is it visible?
No.
Nikita, just press the share screen below. Press that share screen below and select that photo which you wanted to present.
Nice.
Somebody else can put that. Okay. No. You can probably come out. Somebody else can share it. Dr. Deepti. Anyway, you continue to explain. You continue to describe the retina.
Yes, sir. Right eye media is hazy. Disc normal in size, shape, color, margin. Vertical CD ratio is 0.3. Neuroretinal rim healthy. Background, a grayish area suggestive of detachment of the inferior, superior nasal and superior temporal retina. A wedge of Ma'am, this is the left eye picture. Yeah. Thank you. A wedge of attached retina extended from 11 o'clock to 2 o'clock position. Inferior detachment is bullous, which is extending from near periphery to ora serrata from 2 to nearly 10 o'clock hours. Surface has folds with white crests and show undulating movements with movements of the eye. Right eye fundus picture. Media right eye fundus picture. So shall I present the left eye, sir?
Yeah, please.
Media is clear. Disc normal in shape, size, and color margin. CD ratio 0.3. Neuroretinal rim healthy. Background: a break in the far periphery is present at 12 o'clock hour. It is U-shaped, suggestive of horseshoe tear, and has subretinal fluid around it. A linear circumferential band with pigmentation and fine white lines outside the equator, suggestive of lattice degeneration, is present superior temporally at 2 o'clock hours. Peripheral tessellations are present. Background vessels are normal. Macula foveal reflex present. So my provisional diagnosis is right eye, senile immature cataract with subtotal macula of rhegmatogenous retinal detachment. Left eye, senile immature cataract with horseshoe tail.
Horseshoe tear in the retina.
Yes, sir.
Retinal horseshoe tear.
Yes, sir.
Okay. Dr. Guru Prasad, Dr. Sandeep.
I'm calling them, sir.
Okay. Now, how do you want to actually manage this case?
Dr. Nikita,
Yes, sir.
Dr. Nikita, you said floaters. Okay.
Yes, sir.
In history, you said floaters. It is always, once you finish history, better
Yes, sir.
you summarize the history and then take the examiners to a point that both you and examiner should have at least 2 or 3 DDs. Okay. You said in
Yes,
history,
sir.
floaters followed by then sudden loss of vision. So, what are the reasons floaters followed by sudden loss of vision?
PVD causing VH.
Okay, one is PVD. Okay, sudden loss of vision due to vitreous hemorrhage. Better to use complete words
Yes.
like vitreous hemorrhage rather than VH in case presentation. Huh? Okay,
Yes, sir. Yes, sir.
in exams. Okay, try to avoid short forms in examination. In
Yes, sir.
exams. Okay, one is PVD. Second is floaters followed by sudden loss of vision.
Retinal detachment.
Okay.
Vitritis with retinitis.
Yes. Very good. Vitritis. Also floaters followed by it may have a exudative detachment.
Yes,
Right?
sir. Yes, sir.
Okay. Continue.
Yeah.
Dr. Vinita, please continue.
Yes, sir. Case presentation, sir.
No, diagnosis.
Diagnosis: right eye senile immature cataract with subtotal macular of rhegmatogenous retinal detachment. Left eye senile immature cataract with horseshoe tear in the retina.
So, a left eye diagnosis is incomplete, I feel. You cannot have a diagnosis of this short form, senile immature cataract with horseshoe tear, and you have to mention the retinal status. Once you it's a horseshoe tear is not a diagnosis. It's a finding. It's a clinical finding. Okay, it cannot be a diagnosis. What is the diagnosis in left eye? Can you change it?
Senile immature cataract with presbyopia.
No. No, you tell the status of the retina. That will finish the diagnosis.
Okay,
Left eye
with,
senile immature cataract.
with horseshoe tear at 12 o'clock position and lattice degeneration superiotemporally.
With
macula on.
With macula on.
Yes, sir.
No, horseshoe tear with retina attached or detached?
Attached, sir.
Attached.
Left eye attached, sir.
Left eye retina attached.
Yes, sir.
Okay, macula. Then once you tell retina detached, then you go for macula on and off. Okay, once you tell retinal detachment, then you have to, next step is to go to tell us macula on and off. That is next. But
Yes.
once you have to tell the retinal status for complete diagnosis.
Yes, sir.
No, why are you
Then-
actually mentioning macula on or off? Why it is important?
For management, sir, if it's we need can
So there are
vary.
two retina surgeons here. Whether it is this macula on or off, they are going to operate it. No, why they are worried about macula on or off? And which is an emergency? Macula on or macula off?
Macula off, sir.
Dr. Nikita, you should be confident. Whatever, if you tell false also no problem. Means if you tell wrong also no problem. But you be confident in case presentation, in exams, in your exams.
Yes, sir. Sir, macula on with superior RD has to be treated immediately since it can progress fast and involve the macula subsequently.
No, sir, question was whether macula on or macula off is an emergency. Whether macula on is an emergency or macula
Which you will
off is
take
an
immediately. Which you will take at your convenience.
Macula on immediately.
Yes, good. So now you got the thing. Macula should not be detached.
Yes, sir.
Then you will have some amount of irreparable damage that will happen even after a good retinal surgery. So if
Yes.
the macula is on,
Immediately.
try to attach the retina as quickly so that you prevent a retina macular detachment.
Yes, sir.
Right. So macula on is an emergency.
Yes, sir.
Right. So how do you want to manage this case? They want to know how do you manage this case.
The pneumatic retinopexy.
No, management should be like a diagnosis. You have to tell management of right eye, then management of left eye. Or in the priority, which one you are going to manage first, and then which one you are going to manage second.
Okay, sir.
It should be precise.
Yes, sir. The right eye, since left eye has a lattice degeneration and a horseshoe tear, I would like to do a barrage laser first in the left eye. Then coming to right eye, drainage, I would like to go ahead with pars plana vitrectomy, drainage of subretinal fluid, then cryotherapy, and replacement of the vitreous.
Your diagnosis is not not so what they say, not so are comfortable. You are not comfortable, or neither your diagnosis or treatment is not comfortable. Tell the management in one word: management of left eye and management of right eye in one word. Left eye, you told correctly. It has to be barraged or sealed. It should be sealed immediately.
Yes, sir.
Left eye. Okay. Then what about right eye? What is the procedure you are going to do in the right eye? If you know, you tell. Otherwise, you tell briefly. Want to do a retinal detachment surgery.
Yes, sir.
Instead of telling part cryo, fluid drainage and all, you can tell I would like to do a retinal detachment surgery in the right eye and attach the retina.
Yes, sir.
Okay.
Yes, sir.
Make it simple. If you don't know the depth, better to make it simple.
Sandeep, can I ask some basic questions?
Yes.
Yeah, so the patient has NS3 with PSC cataract, I think, no? That's what you mentioned in the antecedent examination, Dr. Nikita.
Yes, sir.
So have you been comfortable with the findings of the retina? I mean, have you been able to make a correct, proper drawing for this patient? I saw your drawing. It looks complete, but most important thing before the drawing is maybe at the beginning of the drawing, you should write whether the view was good or compromised. Meaning whether you were able to document all the findings in the retina or not. See, the picture is so hazy. You can't see the disc so well. In the right eye, at least, it is NS3 you have written.
Yes, sir.
That's what you presented,
Yes.
isn't it?
Yes, sir.
NS3. So with NS3 cataract, is it possible to have a good view of the retina?
No, sir.
So what are the prerequisites for a retinal surgery? Before we embark on treatment of a retinal the detached retina, what are the prerequisites? You should be able to see the retina well, isn't it?
Yes, sir.
So what are the modalities of treatment in this patient?
Phacoemulsification.
1 minute. What are the modalities of treatment of the retina in this patient? One is you said pneumatic retinopexy. I am not sure whether you know the exact procedure or not. I'll ask you, of course. Second, you mentioned something which was similar to still buckling, which you didn't use. You didn't use the word, but you mentioned the steps involved in still buckling. And the third is any idea what the third could be? Pneumatic retinopexy, still buckling, and pars plana vitrectomy. Okay. So which of these three is going to benefit this patient?
Pars plana
optimally. Pars plana vitrectomy, is it?
Yes, sir.
How can you see the retina with the cataract?
Phacoemulsification has to be done prior.
Prior.
Yes, sir.
Okay. How many days prior? Or can't you combine the two?
We can combine the two.
What will you combine? Phacoemulsification with vitrectomy, or phacoemulsification with pneumatic retinopexy, or phacoemulsification with scleral buckling?
Phacoemulsification with pars plana vitrectomy.
Okay. So the most important thing is you should be able to see the retina well and make a proper, accurate drawing. Okay.
Yes, sir.
One more thing about the drawing itself is whether you could see the ora serrata in this patient. Have you indented this patient and seen the ora serrata?
1 minute. No, sir.
One more thing before that is that you have mentioned that the right eye was pharmacologically dilated,
yes,
but the left eye was RRR against the pupil. You mentioned that patient has round reactive pupil,
yes,
round regular reacting.
Yes.
So how did you see the retina in the left eye? In the exam, you are supposed to see the patient undilated.
Yes.
And then dilate the pupil. In the meantime, when the pupil is dilating, you are allowed to see other patients in that period. It takes about 45 minutes for a good dilatation. In that, you are allowed to go over to the other case and see the other patients. So you will not be given a dilated patient always. Some centers may give you a constricted pupil and you have to dilate it later.
Yes.
So how you will manage this with phacoemulsification first. NS3 is, I think, too much for good visibility of the retina for any procedure. May it be pneumatic or scleral buckling or vitrectomy. So we will have to take care of the cataract first, explain to the patient the need for a second operation, and then do the second operation. After the eye is rendered pseudophakic, which is the best procedure of the three? Which is the best procedure of which you will do for this patient? When the eye is pseudophakic,
Yes, sir.
which is the most useful, or which procedure can give you the best results for this retinal detachment?
In this case, sir,
In this case,
pars plana vitrectomy, sir.
Can you try pneumatic retinopexy?
Since superior retina is attached,
I
rheumatic.
think Sandeep told when in the beginning, in the first case, I think he told, can this be, can you use, can you try? When you ask in such a way, you should say yes.
Yes, sir.
Dr. Sandeep, am I right?
Sir, good evening, sir.
Good evening, Sandeep. So, yes, in fact, you can try pneumatic retinopexy in this patient also, but in the postoperative period, sometimes there is a PVD and the new breaks tend to form, and therefore pneumatic retinopexy may or may not succeed. Therefore, you may try, but it may or may not succeed. That should be the answer. How
Yes,
about
sir.
scleral buckling?
Scleral buckling, since it's in the posterior pole, scleral buckling would be tough.
What is in the posterior pole? What is in the posterior pole? What do you achieve in scleral buckling? You are treating a peripheral break, isn't it? You're treating a peripheral horseshoe tear.
Yes, sir.
So after cataract surgery, you are going to do a fundoscopy, proper fundoscopy. You are going to ensure that all the findings are documented. No lesion is missed. Both for pneumatic retinopexy and scleral buckling, the most important prerequisite reason, the point is to see that you don't miss any breaks. If you miss a break, both will fail. Pneumatic retinopexy also will fail, and scleral buckling also will fail. So you have to ensure that that was the only break and there is no other break, right?
Yes, sir.
So how can you do scleral buckling in this patient?
Yes, sir.
You can do.
Yes.
So can you do it within 1 week of cataract surgery?
Yes, sir.
What advice will you give to the cataract surgeon? You are a retina surgeon. You have 10 years experience. You have stopped doing cataract surgery. So somebody else does cataract surgery for you. What instructions will you give to the cataract surgeon before you embark upon the second surgery of scleral buckling? For example, in this patient. Any special way or technique or post-operative protocol the surgeon has to adopt? Should he put a suture to the wound, to the echo wound? Should he do a large rhexis to enable you to see the peripheral retina?
Yes, sir.
Should he not put the lens in the bag for a proper centration?
Proper
Should
centration.
he polish the posterior capsule? So a clean cataract surgery is essential, isn't it? So all these instructions you'll give to the cataract surgeon before you do any retinal surgery.
Yes, sir.
So in this patient, you will do vitrectomy, but why not scleral buckling? And okay, before that, how does scleral buckling actually help this patient, or what are the mechanisms by which scleral buckling acts?
It indents the sclera and gets the opposition of the detached retina to it.
What else? What else does scleral buckling do? How do you achieve that indentation? What material do you use?
Silicon explant.
Silicon?
Silicon explant.
Explant. Okay. What is it? Silicon? Silicon oil or silicon rubber or silicon fiber or what? What is it?
It's a rubber.
Rubber. Solid silicon rubber. Correct. How do you anchor it to the sclera and how do you achieve indentation? Just keeping it there will not help, no?
No, sir.
It has to be pressed against the sclera. So what do you do to keep it pressed against the sclera and cause indentation?
There's a sponge in between the.
No, whatever it is, whether you use sponge or rubber, it has to indent on the sclera.
Yes, sir.
How do you achieve that indentation? Have you seen a scleral buckling?
No, sir.
Have you read about scleral buckling?
Yes, sir. Yes,
Can you use sutures? Can you use sutures over the silicone rubber that you're talking about and tie the sutures in such a way that it causes indentation?
Yes, sir.
You can. Okay. So that's the way. Anything else you do along with this silicone sponge being used for indentation? Anything else you do?
Drainage of
For
cryo,
drainage?
cryo and drainage of the
Cryo.
fluid.
It is not cryo, it is cryo. Okay?
Cryo.
Cryo and
Drainage of the
drainage.
subretinal.
Where do you put the implant? Where do you put the explant?
Exactly, like it should cover the tear on all the sides.
Very good.
Sufficient
Exactly on
margins.
the tear. So how do you do that? How do you know that it is covering the tear?
There is no the indentation, like after placing we examine the retina, then it should be covered, sir.
Before placing, you will localize the tear on the sclera. You will find out where on the sclera the corresponding retinal tear opposes. The retinal tear should, when it reattaches, it should come to a point on the sclera which you are going to localize with a marker.
Yes.
And on that point, you will put the silicone rubber for indentation.
Yes, sir.
Okay. Anything else you do apart from cryo, apart from silicone rubber for indentation, apart from drainage? Anything else you do?
We replace the vitreous.
You replace the vitreous with what?
No.
Artificial vitreous.
No, sir.
Then
No.
you don't do anything. You don't do all those things in scleral buckling. You don't even touch the vitreous. At the most, you may inject an air bubble.
Yes, sir. Injecting.
An intravitreal injection of an air bubble, but you don't replace anything. Replacing is only in vitrectomy surgery.
Yes.
Okay. So you will put an encircling band also. That's the answer I wanted from you. You will put an encircling band. You will put a segmental buckle on the tear. You will do cryo before that. You will drain the subretinal fluid after that, and you will put an encircling band all around to reduce traction in 360 degrees. Okay. And what do you do in a vitrectomy? What do you achieve by vitrectomy?
In vitrectomy, we basically central core of vitreous is removed and detached. Subretinal fluid is drained. Breaks
from where? Sir? Subretinal fluid is drained from where?
Break, sir.
From the break. How do you drain? Have you seen vitrectomy being done?
No, sir.
Have you seen videos on YouTube?
Yes, sir. Perfluorocarbon liquids can be used and drain the subretinal fluid.
So how does it help? How does PFCL or perfluorocarbon liquid help in draining the subretinal fluid?
Yes, sir. Since it's having a high specific gravity, it will the detached retina gets back to its place, and the subretinal fluid can be mobilized towards the hole.
Good. Okay. So what else you do? You do cryo in scleral buckling. In vitrectomy, what do you do?
Cyclophotocoagulation.
Cyclophotocoagulation is photocoagulation of the ciliary body. Why do you want to touch the
This
ciliary
is just
body?
photocoagulation.
Photocoagulation of the retina. You barrage the retinal hole.
Yes, barrage. Yes.
Barrage. You do an endo barrage or endo laser to the retinal tear. Okay. What else do you do? You've done vitrectomy, you've done the laser, using PFCL and attach the retina. Can you leave PFCL behind like that? You can't leave, no?
No, so
you can leave in certain situations, but not in this patient.
Silicone oil can
use extended tamponade. You can say extended tamponade.
Extend air fluid exchange.
Don't say silicone oil. Yes. In this particular patient, silicone oil is not required. You can do fluid air exchange or add gas to keep the gas for longer.
Yes, sir.
Tampon at the break. Okay. Extended tamponade, either in the form of gas, expandable gas, or silicone oil.
Yes, sir.
Okay, coming to the first question which Dr. Sandeep asked, which eye is the one you're going to address first? The right eye or the left eye?
Left eye,
The
sir.
left eye is not yet detached.
Left eye, sir.
It has got a high risk for detachment.
Yes, sir.
The right eye is already detached.
Yes, sir.
It's not an emergency.
Yes, sir. So
And
left
before
eye.
that, Dr. Krishna Prasad asked, why is macula so important? Why should you worry about macular detachment? If the macula is not detached, why are you worried more for that eye?
It subsequently can involve macula and get detached in that.
Correct. So why should the macula not get detached? Anyway, you're going to do a retinal surgery. You're a retinal surgeon.
But the duration between the detached the prognosis matters, sir.
Why does it matter?
For the nutrition of retinal
If you
pigment.
get detached today, tomorrow you're going to reattach. In one day, what will happen? In one day, what can happen in one day?
Retinal pigment epithelium and retina suffers nutrition.
In one day it will suffer nutrition and become weaker. Solid. I think it is little too much for you, but remember, the photoreceptors and the RPE cells both have got interdistating microvilli,
Yes.
which enjoy a one-to-one relationship. And if this gets disrupted, it can't go back and get restored. That one-to-one relationship cannot get restored, and that is why these patients complain of metamorphopsia for life. So even if the retina is detached for 1 hour, okay,
Yes.
the relationship cannot be restored, and sometimes patients can have metamorphopsia. So even if the visual acuity is good, 6/6, they will have some deficiency in the quality of vision. Right.
And sir, with your
Yes.
permission, second thing is the burden of the procedure. Why you want to make the patient burdened for a bigger procedure when you can prevent so many things with a smaller procedure? Huh? Okay, and
Yes.
it is second eye is emergency, and the first eye is urgency. Okay, there is a difference between emergency and urgency.
Yes,
So
sir.
emergency has to be done tuck, but urgency it has to be done in a short period. Means it has to be done. It is not a uh, slow procedure, or you can wait for a long time. Better to operate as early as possible the detached retina. Also, as sir said, it has to maintain a good relationship. It has to be attached as early as possible. So left eye is a emergency and right eye is a urgency, right?
Yes, sir. Yes, sir.
Okay. And what as a being a PG, you have to know if you get a case of retinal detachment, please better to be theoretically sound. One is principles of buckling surgery. At least you should tell three or a principle of buckling surgery. And when you are telling about pneumatic retinopexy, you have to read a little about pneumatic retinopexy. Means what are the common indications where you will do pneumatic retinopexy as a postgraduate student. At least this much expectation will be there from you. What are the indications of pneumatic retinopexy and this principle of buckling surgery?
Yes.
If you tell the principle, that is enough.
Yes.
If you can't narrate the procedure and all, at least principle of the retinal detachment surgeries, especially buccal surgery, you have to tell in one sentence or two sentence.
Yes, sir.
Okay.
Yes, sir.
Don't get panic when you get a case of retina, or if you don't know the case which you have not seen much. You be stuck onto your basics. Tell in a simple way. hmm, Be honest. That will clear your exams.
Yes, sir.
Okay. Thank you.
Yes, sir. Okay, I think thank you, Dr. Guru Prasad. Thank you, Dr. Sandeep. Thank you, Dr. Pawan. So I think with this we come to the end of this day's uh, our web version of Eye to Eye. We'll have presented 3 cases. Having said that, the 3 girls have really done an extremely good job. It's not easy to come and present here. At the same time, there is a lot for improvement. You can keep on, working on this. Try to present more to your own friends, and also try to be ready for all the variations of the case. And as you said, be logical. Don't waste time in the formalities. Tell the most important thing, as Dr. Sandeep said. You should know exactly in the history and examination what are the most relevant findings or the summary, which actually lead you to the differential diagnosis and diagnosis. And always tell something about the management. And in the back end, be ready for all these cases, the theoretical questions. As you said, it's a retinal detachment. Obviously, you should know all the different strategies for retinal detachment management, surgical management, and also the principles of each one of them, and the actual indications and contraindications and the problems of each one of them. So just do a lot of homework on these, and tomorrow we'll meet you at 7:30 once again. I thank all the participants, including the panelists, for a wonderful session. Thank you so much.
Thank you,
Thank
sir.
you, sir.
Thank you, sir.
Thank you, sir.